USMLE Step 1 QBANK, continuing on with cardiovascular system, presented by USMLE Forum of Pakistan. A 75-year-old male with a history of hypertension, CAD, and heart failure presents with lethargy and confusion. On examination, he is hypothermic with a core temperature of 95 Fahrenheit. He has hypotension, he is tachycardic, and he undergoes pulmonary artery catheterization with high cardiac output. So this is where the information starts. High cardiac output, low central venous pressure, low pulmonary capillary wedge pressure, and high mixed venous oxygen saturation, low systemic vascular resistance. Which of the following is the cause of the hypertension? Now, looking at this question, you can already identify that hypotension and hypothermia and tachycardia and present acute presentation of worsening health status. This all is pointing towards shock. Now, shock can have hypothermia or hyperthermia. It is one of the components of systemic inflammatory response syndrome. It can have hypothermia or hypothermia. It does not have to be one or the other. But in this question, we have hypothermia. It mostly presents with hyperthermia or fever, but it can present with both. So you need to remember this constellation of hypotension, tachycardia, general worsening health status presenting acutely, and also hypothermia or hyperthermia. All right. This is a type of shock. We have to identify what kind of shock it is. So if it has high cardiac output, it is definitely not cardiogenic shock. If it has, or a more specific marker, is low pulmonary capillary wedge pressure. If PCWB is high, you have to stop looking at the question and then just directly mark cardiogenic shock. There are 4 different types of shock: hypotensive, cardiogenic, obstructive, distributive. So if PCWP is high, it is cardiogenic. If it is low, then it is not cardiogenic. So anything related to the heart is the wrong answer. Cardiac output is also high. Now you have to understand that there is low central venous pressure. If this is high, then it is obstructive shock. If this is low, then it is not obstructive shock. So it cannot be a pulmonary embolism, which is a kind of an obstructive shock. All right. Hypothermia does not give rise to shock-like state until and unless there is extensive history. There is no extensive history of the patient getting exposed to the cold environment. So we are left with 2 options: GI bleeding or bacterial infection. Now, bleeding signifies hypovolemic shock, which means there is less volume of blood in the body, which means that cardiac output should be low if it was hypovolemic shock, but it is high. Cardiac output is high. So naturally, our answer is bacterial infection. This is septic shock, a subtype of distributive shock. All right, so you have to remember, guys, PCWP is cardiogenic, signifies cardiogenic shock, high PCWP. High central venous pressure signifies obstructive shock. High cardiac output or low cardiac output. Low cardiac output signifies hypovolemic shock, and high mixed venous oxygen saturation also tells us that the heart is working fine. Because if this was low, then it means that the blood was moving slowly through the veins and more oxygen was getting extracted. But as the flow of the blood is high, because heart is pumping uh, in its right state, then the tissues are not able to extract all the oxygen out of the venous system. That is why the oxygen remains high, which also shows you that the heart is working fine. So you have to know these associations. Continuing on, this is for your reference. Please view this. All of these shocks. Just a quick revision. Pause the video and see this for yourself. These are important. High yield table. You have to know this. Moving on forward. So, 43-year-old man, emergency department, 3-day history of persistent headaches, poorly controlled hypertension history, and blood pressure is to 24. This is very high. Bradycardia. There is mild confusion and no focal neurologic deficit. Fundoscopic examination reveals papilledema. Laboratory studies show 1.4 creatinine. Patient is started on intravenous medication that produces arterial vasodilation while simultaneously improving renal perfusion and enhancing natriuresis, which is the following agent. So you have to keep in mind that they are asking for a specific pharmacologic agent that can do number one, arterial vasodilation, increase renal perfusion, and also enhance natriuresis. So you have to know that pharmacologic agent. Pharmacology is mostly memorization, so I'm just going to tell you that, or it's better if you should go through the options. So esmolol is a beta blocker. All right, so this will not undergo arterial vasodilation. This is a beta blocker. Okay, so this is the wrong answer. Because beta blockers have no effect on arteriolar vasodilation. Hydralazine, hydralazine, excuse me, is an arteriolar vasodilator. All right, let's look at others. Nitroglycerin is also the wrong answer because this is a venous vasodilator. Venous. And phenylephrine is an alpha agonist. So this is also a wrong answer because it is going to vasoconstrict. It's going to vasoconstrict, and this is going to vasodilate. This is also arterial dilation. Phenol-dopam is an arteriolar dilator. It is a dopamine D3, D2 receptor agonist. Now, what is the difference between hydralazine and phenol-dopam? Because this is also a dopamine receptor, so this is going to dilate the receptors, dopamine D3 receptors present in the renal parenchyma. That is why it is going to increase renal perfusion. Hydralazine has no renal effects. No renal effects. Okay. Although it is a arterial dilator, but it has no venous effects. So phenol-dopam is the right answer. It is, remember, dopamine agonist. So it has renal effects and also an arterial vasodilator because dopamine receptor causes vasodilation. Hydralazine is mostly used in pregnant females to combat hypertension. It is an intravenous form, so you just have to know this important point about it. And nitroglycerin is used in acute STEMI to decrease workload on the heart. All right. So 45-year-old male presents rural emergency department. Sudden onset of chest pain, diaphoresis, nausea 1 hour ago. This looks like a MI, but let's read. He has a family history of sudden cardiac death and has a smoking history. The ECG demonstrates ST elevation in lead 2, lead 3 AVF. So this is an STEMI. And after initiation of medical therapies, chest pain improves, but he develops a transient asymptomatic reperfusion arrhythmia without intervention. The following medication administered as part of the initial treatment is most likely responsible for reaching rapid reperfusion. So you have to identify what they're asking. They are asking the reason for the pharmacologic agent that reaches rapid reperfusion. All right. So looking at the options, we know that statin cannot be the right answer because statins do not have any part in hemodynamics of the body. Right. Prasugrel is also a P2Y2 inhibitor, so it has no part in reperfusion. It is an anticoagulant, P2Y12 inhibitor. And heparin is also the wrong answer because it is an anticoagulant. So it has no part in um, reperfusion. Aspirin is an antiplatelet agent used in dual antiplatelet therapy for people that have undergone STEMI or PCI and are now maintaining their hemodynamics in favor of anticoagulation, so that clots do not reoccur in the circulatory system or in the heart, anywhere in the body. Agatroban is again an anticoagulant, so this is not used in reperfusion. Specifically, it is not used in reperfusion. Agatroban is oral oral factor 10 inhibitor, I think. Direct thrombin inhibitor, yeah. So direct thrombin inhibitor. This is a direct thrombin inhibitor. And apixaban is a direct factor 10 inhibitor. So I just mixed up both of them. So it is an anticoagulant agent, again, direct factor 10 inhibitor. 10 inhibitor, right? X represents 10. So alteplase is the correct answer because this is a thrombolytic agent. So you have to remember that it is a thrombolytic agent. So it thrombolizes, it breaks the thrombus, it breaks the clot. All right. The rest of them do not. So these are pharmacologic agent questions. This is just basic information. There is no concept, and then you have to know what each drug does. And this way, it is easy for you to remember. So all of these are anticoagulants. Aspirin is antiplatelet, used in dual antiplatelet therapy with the P2Y12. These two are used together, passively aspirin. And statins are used in hyperlipidemia. Okay, so a woman presents in emergency after being struck by tree branches, broken glass in thunderstorm. And she has a deep penetrating wound to the left chest, 4 intercostal space near the left sternum bladder. She's hypotensive, tachycardic, signs of hemorrhagic shock. Our physical examination reveals smaller forearm lacerations, all right. Which cardiac structure is most likely injured by her penetrating trauma? So this is what they ask basically. That what cardiac structure is penetrated? This is an anatomy question, right? So they're saying that penetrating wound at the left chest at the 4th intercostal space near left sternal border. So basically the anterior side. So the anterior surface of the heart. Looking at this picture, so this is the anterior side, right? This is the anterior side. And somewhere here, the penetration has occurred. Because this is a lateral surface. All of this is a lateral surface, right? This is the anterior surface. So penetration has occurred somewhere here, this is the right ventricle. The right ventricle, right? This is our answer. Right ventricle. Why cannot other things be simple anatomy? If they would have said that in lateral surface, it has penetrated in the lateral surface, because they say that it is near the left sternal border, right? The left sternal border. But if they would have said that mid-axillary line or something along that line, so it could have been the lateral surface. And if they would have described the posterior surface, then that could have been the posterior surface could have been the left ventricle and the left atrium together. This, as signified by this. So this is the left ventricle. So that could have been the posterior surface. Lateral surface consists of some part of the left ventricle and some part of the left atrium. I think mostly it is left atrium. So that you have to remember. This is basic anatomy question. Nothing too difficult. Inferior vena cava is not anterior or in the left side. So that cannot be the answer. Left anterior atrium, I've told you that it is the left lateral surface or the posterior surface. Sorry, left ventricle is the lateral surface, right? So left atrium posterior surface, left ventricle lateral surface, and pulmonary trunk is the superior surface, and anterior vena cava, inferior vena cava is retroperitoneal, so it is not anterior. Okay, so you have to remember your relations of the organs. All right. So a man has proximal AFib, and these are the results of exercise test testing. And I've told you guys what is exercise stress testing in the previous video, so you have to view that. These are the results. Okay. So if you look at the results, you would know that QRS duration has increased, but the QT interval is the same. It's 410 and 400, so it's mostly the same. This has basically increased. You can say the QRS duration has increased. So they're asking again, what pharmacologic agent is used to treat is AFib, which means what pharmacologic agent is increasing the QRS duration. So digoxin will not do that because digoxin is not an antiarrhythmic agent, right? Atenolol is again a beta blocker, so it has no QRS widening. Let me explain you a simple concept. So QRS widening depends on sodium channel blockers, and QT prolongation depends on the class 3 antiarrhythmics, which is dofilitide and dofetilide and amiodarone. So we could see that QT prolongation is not here. So this is the wrong answer. Atenolol does not block sodium channels. Digoxin does not block sodium channels. So both of these are the wrong answer. Just by that logic. If you remember this mnemonic, sort of, which is not a mnemonic, this is the real physiology, then you would understand that QRS channel prolongation is done by sodium channel blockers, and QT prolongation is done by class 3 antiarrhythmics, which is amiodarone and dofetilide. Right? So class 1 antiarrhythmics will be implicated in this case, which is flecainide, because it is a sodium channel blocker, sodium blocker. Also, it is class 1 antiarrhythmic. All right, so you have to remember that. This is class 1C. You have to remember class 1, which has quinidine, prokinamide, and class 2, which has lidocaine. You have to remember these. Verapamil is class 4. Again, class 4, the wrong answer because it is a calcium channel blocker, not a sodium channel blocker. All right, so you have to remember this concept that I just explained to you, and you'll be fine. All right, so this is it. Thank you for watching.